So, a lot of you are probably at the physical exam in service where we sidetracked into functional points of the exam and conversion disorder. And then I hear that, I don't know if I've seen more recently, maybe, but I heard you guys have maybe been seeing more functional patients recently. And I brainstormed that maybe that's, I think anecdotally I probably do every spring, because my own personal theory is, that's when the light, the light changes so drastically in the northern latitudes that a lot of the psychiatric disorders, more bipolar and mania, really kind of flare up that time of year. So maybe it has to do with that, but that's just a good conjecture since it is that time of year. And so maybe we'll see what I do. But I'll sit down first. I was going to do a physical exam. So for those of you who weren't there, we talked about some of the physical exam findings. But to start with, conversion disorder is one of the sort of triad of psychiatric disorders that involve symptoms or signs of disease. Almost always it's neurologic, although there are some GI conversion disorders and things too. That's more called somatoform disorder. So symptoms or signs of a neurologic disease that don't correlate with any actual neurologic disease. So it's something is in the mind is doing this. And of the three, there's conversion disorder, factitious, and malignant. It's going to be like a review for everyone. Conversion is the one that is theoretically subconscious, not consciously done, associated with a lot of comorbidities and things that we'll talk about. Whereas factitious and malingering are actually consciously done. I'm weak in my arm and I can't move it, and I know I'm not going to move my arm. That kind of person. So they're not probably so sinister. But, well, for the factitious person, they're not moving their. Maybe they are. That'd be funny to catch them on video doing that.
I'll just follow you around.
Yeah. So for the factitious person, they're not moving their arm because they really want attention. They want help, the healthcare service. They don't want any personal gain out of it, and that's what separates it from malingering. Malingering, they usually want either money or to get out of jail or something like that, get on disability. And malingering can be an actual crime. And so you start using that word, you should be careful. And I always like to try to get the psychiatrist back before I start actually diagnosing malingering, even though it's pretty obvious sometimes when the folks come in from jail with a pseudo-seizure and they're having a pretty traumatic event in time in jail. And jail itself is obviously one of the most traumatic things you could possibly imagine. So they're probably just trying to get out of it. But I would still call it conversion disorder. I usually defer. The conversion is sort of the default because you can't, whether something is consciously willed or not, it's unbelievably hard to decipher. One of my professors was Bob Daroff, who wrote one of the big books on neurology. He was one of the gods of rock and roll. He's one of the gods of neurology. And he pointed out he was the only neurologist in Vietnam, so he saw a lot of the vets came to him for different things. And one of his, I think I've read the story exactly, I think it was actually one of his co-worker, colleague, psychiatry docs, got out of, wasn't fighting because of a disability of the leg, which Dr. Daroff, everyone knew it was functional, even the guy knew it was functional, but he couldn't say it was, what was his story? I'm going to get it messed up. He couldn't say it was conscious or not, even though Dr. Daroff would see him down the hallway walking just fine. And then when the guy noticed that someone was seeing him, the limp would kind of start to appear again. And Dr. Daroff called him on it and said, you have to be full of it, right? You have to know that. You saw me. And he's like, no, I don't. And how can you can't prove it? It's like proving pain. Pain is something that you can't prove or not. So I default to conversion disorder and let psychiatry figure it out. Because, like Janice and I just talked about yesterday, because if you really want to get into it, it really does involve at least an hour long, put them on the bed and tell me about your mother, Freudian kind of thing. And none of us have time for that, one. And two, you might be opening up really traumatic events in their past that we're not professionals on really doing this. So, we all probably go into the psych stuff a little bit. We want to be compassionate and everything, but even one of the recommendations, and I just kind of reviewed this again, was if you're, when you start to go into the probable trauma in the person's past, you probably want to wait to the very end of the encounter when you've developed some trust, or even maybe a follow-up visit, because that's usually there and you want to get into it at some point. So that's conversion disorder. So we're going to talk about the conversion disorder, the one that's subconscious, some neurologic disorder. For epilepsy, it's the pseudo-seizure, which can manifest as any type of seizure. But there's also a functional weakness, and a lot of you guys have seen all this stuff probably. There's functional movement disorders, so functional tremors or gait disorder. There's just functional anything, any of the neurologic disorders people can have as a conversion disorder. So when I reviewed it again, I thought a good way to do it is pretend like we're seeing a patient like an H&P or a consult note, where you have like chief complaint, you have HPI, you have history of health, and then you have your family medical history and social history and meds. I don't think we need to worry about others, we don't need to worry about. And then you do sort of a physical exam findings, and then you do an assessment and plan or treatment. And that's what we should all brainstorm on, fixing this problem once and for all for Snohomish County. We're going to come out of here fixing conversion disorder once and for all. So chief complaint we just mentioned could be any one of these things. Could be the seizure, could be a weakness that seems to be functional. I'll skip this present illness because that could vary for patient to patient based on the chief complaint. But these are interesting points on what are the remembering what sort of past overview systems is important. So what sort of family medical history might a patient with a conversion disorder have? Oh, past medical history. I didn't get past medical history. I missed a bunch of these. So family medical history, they often have family members that have real disease, and you don't know if they subconsciously, pick up on it. Like a lot of patients with conversions, pseudo-seizures, have family members somewhere that have real seizures, and they've seen the real seizures. Maybe they've seen the attention they got. Who knows what's going on psychologically. But they'll often have quote-unquote real disease in the family somewhere that might be similar to their own issue. Social history, what kind of social background is it? I mean, anyone can have conversion disorder, but what's more probable for social background histories?
Abuse.
Yeah, I mean, there's abuse that might be past medical history too. Some sort of abuse might be going on, whether past physical or rape or something, domestic. Yeah, and then psychosocial stressors. And I forget the word that they use in the review article. The psychosocial downward spiral of all the different stressors that psych puts at the top of their list, like homelessness, and drug abuse, and deaths in the family, and whatnot. All of those increase when you have conversion disorder, and if you have those, you increase the risk of a conversion disorder. They totally play into part.
Oh no, I was just gonna say for social history, typically like death in the family or like new homelessness or like they're at risk of being homeless.
So
job loss.
So stressors, I mean, just all the stressors,
Yeah.
all the stressors. And then actually, you guys have probably seen me, you guys have probably done it too. When you come up with someone, you kind of can tell this is probably functional. You sort of say, but you start with the, ruling out the possible physical things. You want to be fair, even though if it's blatantly obvious sometimes. You'll go through the review system stuff for MS or seizures, or risk factors for seizures. Have you had concussions? And then you'll start to kind of segue into the stressors. Has there been a death in the family? Relationship problems? Divorce? Have you just moved? Lose a job? You go into the kind of the big ones, and you might pick out those. Review systems in general. So that's going through the whole list. You guys probably I have like my own 10-step memorized. I try to go through as fast as possible without patients slowing me down. I don't need to tell you about every little stupid stomach ache you've had for a month. I just want to know, do you have any fevers, chills, weight loss, chest pain, shortness of breath, cough, dysuria, nausea, vomiting, diarrhea, constipation, bowel or bladder changes, rash, swelling, bleeding, joint pains, depression or anxiety? Yes, no to all of them. Let's move along. Medicare requires this, and maybe it's not going to heal it, but I don't need to know about every little toenail thing you've had. Right? Do you guys have to do review systems in general? So in general, and it's actually been studied, people with conversion disorder definitely have the positive review systems. You're going to be checking off yes on almost everything, and in detail. If you don't kind of finally just say, hey, you got to speed it up a little bit. Someone did a study of someone with real stroke versus conversion disorder stroke. The conversion disorder stroke people have a statistically significant increase in how many check boxes on the review systems they're going to have, as opposed to someone with neurologic disease.
A lot of times it's somatic, and this guy goes in with review of past medical issues too. A lot of times it'll be comorbid, sort of somatoform complaints, chronic pain syndrome, fibromyalgia, irritable bowel syndrome. Those things that definitely can be associated with anxiety disorders. Some kind of physiologic components too, but the sort of general somatic pain, chronic fatigue syndrome, usually insomnia, and then moving into the past medical history. The other things. What do you think of the past medical issues that can be associated with conversion disorder?
Trauma.
Past trauma, yeah. And specifically, what's the psychological disorder that's associated with trauma?
PTSD.
Yeah, PTSD is big, or depression, and all of it.
Well, they often will have walked into the fact that they've had a stroke before, whereas you look at the documentation and it was
Or
probably
you look at the CAT scan and the MRIs
Yeah.
and you don't see any evidence of any
Yeah,
injury ever.
or that they have a seizure disorder, so they kind of grab that diagnosis,
Yeah, and unfortunately,
whether it's true or not.
there's chart lore. Someone says that, it gets into the
Yeah.
problem list and it's there for life, and then they hit with a brain attack or code stroke. And you're looking and you see the past medical history of all these things, and then it takes, in the decision you have to make TPA, you have to try to figure out if people did their homework in the past or not. So past medical issues, so a lot of the sort of somatoform disorders, and that's another thing in the review systems to go over. And that might be even valid and helpful to treating the diagnosis. So chronic pain, most of the time they will have it, and it should be treated. If you treat real chronic pain, you have a better shot at treating depression and the conversion disorder. Insomnia is huge. We've gotten a lot better about sleep medicine over the past 10, 20 years with all the sleep docs and their polysomnograms pushing their labs. So that's actually a good thing, because there's a lot of good health benefits to getting a good sleep. So these folks will often have insomnia, probably comorbid with depression. That's lowering their pain threshold, and they've got that triumvirate of depression, insomnia, pain. And if you don't attack all three at the same time, you're never going to break out of it. So it's good to review these things and make sure they're being treated. Again, we're not going to make miracles in the hospital, but they're probably I would bet 90% of these folks probably have all three of those issues who have bona fide conversion disorder. Past medical history, besides psychiatric disease, includes the personality disorders. So which one do you know the clusters of personality disorders? We had the mnemonic weird, wild, and worried. Did you guys know this? So cluster A, personality disorders are untreatable. They're not considered disease like a psychiatric disease that can be treated with antidepressant or antipsychotic or whatever. A personality disorder is thought to be inherent to the person's personality. Probably a lot of, obviously psychogenetics that are involved in stuff from their parents and things. But they're considered disorders because they often lead to psychosocial dysfunction, or losing jobs or friendships and relationships and this sort of thing. So they're really hard to manage because it's inherent to the person's personality. It's one of the toughest psychiatric, it's not even a disease, disorders to treat. They have to go through really extensive cognitive behavioral therapy, and even then they probably, it's still very hard to treat. So the weird, wild, and worried. So the weird one is psychoaffective personality disorder, or these sort of things where they sort of seem like they might have psychosis or something because they're acting really strange. And I like fairies, don't you? And you're like, what a weirdo. But they're not really psychotic. And I told that to my kids, and they were like, oh, like Luna Lovegood? And I was like, yeah, that's perfect. It's like Luna Lovegood. And except, I guess there really are fairies in that whole Harry Potter universe for him. But it's kind of like that. They're just kind of bizarro, and that's just kind of who they are. And they're kind of interesting and funny. And then it says the wild ones are your narcissists, your borderline personality disorder, your oppositional defiant as kids that turn into, aggressive, I forget, the folks who are often 50% of the folks in prisons theoretically, because they're just personality is to fight and be sort of psychopathic and not have empathy for anyone. So narcissistic, and histrionic is the other one, histrionic personality disorder.
So histrionic, the word story is in there, histrionic, so they're the ones that are storytellers, they're the dramatists. They have to have drama in their lives, and they have to have drama in your life. And so they're the ones that, and I went to the grocery store, and he told me that I didn't, and I told him I did. Like, okay, you're histrionic, that's cool. I have some the narcissists, of course, are narcissists looking at themselves in the pool and just like me, and lack of empathy for others. Everything's about me, and if you add malignant to it, you got Trump, but let's not go into politics. And then you've got malignant narcissism, histrionic, and so borderline personality is kind of the key one to this whole talk. Borderline personality disorder folks are the post, we talked about this too, because these are the ones that split, where they will love you one day and you'll be like their best friend, and you're the best doctor, and oh my gosh, the other people are so horrible, can I just see you all the time? Oh, my buddy, my BFF. And then you come back the next day and you find out that they told the charge nurse that you were the worst doctor, or that you even like touched them the wrong way, and like, and I'm gonna write you up. And you're like, oh my God, what did I do? And they really just love to throw you around like a yo-yo. They really wig you out. And if you, my rule of thumb at this point in my life is when I realize I'm just not connecting with a patient, and I don't know what I'm doing wrong, and they're just driving me nuts. If I'm being driven nuts by someone, I stop at them. Yeah. 9 times out of 10, they have borderline personality disorder. So keep that in mind. Maybe that's true for you too. And these are folks who like to cut. So instead of the actual suicide attempt, with down the artery, that they do the little cuts. They often have the teddy bear sign, so they'll have a doll or something, or they'll have the big poofy blankie in their bedroom, and they're getting comfy with their slippers. Conversion disorder folks in general can have that as well. Borderline personality disorder folks, what's the other issue with those guys? Oh darn it. You can see how this would be a tragic sort of personality disorder to have, because you're going to, obviously, friendships and relationships are going to keep crashing down around you constantly. And probably depression and real suicidality does eventually, suicidal gestures initially is in the diagnosis, but true depression can follow, because your life is in shambles, as opposed to maybe histrionic, where that was exciting, that shambles that I created. I don't know. I'm not a psychiatrist. That's a psychiatrist.
Dr. Jerry?
Yeah,
what about substance abuse when you're...
That would go in. I mean, that's kind of in that general psychosocial dysfunction with bidirectional correlation, where the more of that, the more conversion disorder possibility, the more conversion disorder possibility, the more of that. So there's the borderline. There's the personality disorders that you might associate with this as well. So then the physical exam findings, we talked about that again, but again quickly, some of the pearls or tricks in the neurologic world. If you have a pseudo-seizure or a psychogenic non-epileptic epilepsy patient, common to all the conversion disorders, you might see distractibility. And I said, please put the word distractibility in your note, otherwise known as, distractibility. Oh, I know, I forgot my little mnemonic for that. Inconsistency. It's the same sort of thing. If you can distract them, like, I can't turn my head that way. Oh no, look over there. That would be distractible. But more likely you'll catch inconsistency when if you watch them, if it's an outpatient, walk into the room and walk out, but then when you're actually testing and they can't move things, or they can't move the arm, but can you get your glasses? Sure, and then they can reach into the bag. Something that they're not thinking about it, it's not being directly tested. Try to really note those moments of distractibility / inconsistency and write them in the chart for sure, because this is all positive signs and evidence that this is helping to diagnose that this is conversion disorder. We've got to have that evidence that this is not real weakness. And discongruity is the other one, where if you've got my face is numb here and my leg is numb here, and it doesn't make anatomical sense to a spine or a brain map, then it's
stocking gloves, sensory loss.
Yeah, except it's like shoulder down,
yeah,
and then leg down. Something that doesn't make any sense that I can think of.
Well, my question was, I I tend to not do standardized testing. Like if I've done a chart review and the word on the street is that there's a psychotic.
The download, this person got the psychotic.
Everybody does whisper it, right? Nobody ever says it out
No,
loud.
we'll get to that in the treatment. We should all be like, right to their face, you got conversion disorder.
But it's true, it's all like that.
I know, I think the main reason why it's still not a very well-treated thing is because the evidence shows it's better treated if people are completely open and honest.
That's right,
Right.
and stress and all that. But I tend to just go straight into functional stuff because I don't want to feed into their, but is there a value to do a standardized test? Because it gives them an opportunity to perform for me when we do a standardized test as opposed to just keeping it all functional,
and you
mobility,
well,
focus.
one, I have, similar with the review systems, I have to do a standardized test for Medicare billing reasons sometimes. So once I get to the follow-ups, I can do more focused exams.
Okay.
But two, I would still do a full physical exam for these folks. One, the biggest scare of everyone with psychiatric functional disorders is that 10% of the time, or whatever it is, they can be real. And the patient with known conversion disorder, 10% of the time, that one's going to come in, that there's something real, and you're going to poo-poo it, like the boy who cried wolf or whatever. So it's good for that reason too, to see if you're picking up on something. And in neurology, we can always find, like you guys too, probably. We get called for headache, and we found out they have peripheral neuropathy, and they have obstructive sleep apnea. You can always find something, even if you weren't consulted for it. So you might find something. One of the treatments for these folks is reassurance. Is really one of the, besides education and physical therapy we'll talk about, is a reassurance that things are okay. So, one, everything else that's working well, and you're like, good, oh, that's great, you're working fine. And then I would like them to perform for me, subconsciously, obviously, if it's conversion disorder. One, because I got to make sure the other docs, I see what they were seeing, see what they were talking about, and maybe they thought it was conversion disorder, and oh no, this is real, especially if it's the first time I guess I'm seeing them. I got to check it out. Missouri State, show me. I got to see for myself or whatever. And two, there are these tricks, that go right for where the money is, like Swifty Lazar, who was it, the bank robber? Why do you rob banks? I go where the money is. The guy said. So if they're weak in the right arm, I better check out the right arm. I gotta verify, and two, I gotta do our own tricks to hopefully diagnose conversion disorder. Which again, you want the positive signs. So looking out for distractibility or I keep wanting to say irritability, inconsistency, and two, do some of the tricks. So the motor weakness tricks, so the giveaway weakness. You guys know all these things. So if you're saying pull with your bicep, and you feel just a little ink of strength, and then, okay, well, it's not like a stroke where they just can't do anything the entire time. There was that little bit of strength. So again, we talk about all this, that part of the brain, the motor cortex works, the nerve down to the spinal cord works, that nerve works, the muscle works, everything seems to be working. It's just at some point there's giveaway, and then you can't prove whether or not that might be pain. Pain can cause giveaway weakness too, so I always try to look for grimaces and ask them if there was pain, and if there's not, then okay, if I've got giveaway weakness, I can document that. That's a positive sign that there was strength in there. I never check for this or mark it, but you can also look for opposing muscles being flexed at the same time. Where you guys used to do all this. So like the bicep and tricep are going at the same time. You're saying your bicep seems strong, but you're not moving. Oh, your tricep seems strong, or whatever. So you can mark that. The Hoover sign is well studied and works well. So that's again, what they're lying on the bed. We talked about that too. The external rotation of the leg. You need a little bit of tone to keep your feet up like this. So right away, if you've got someone with a flaccid leg but their feet are up like that, you can just note that. So if I see that, I come in right away thinking, this might not be bogus after all. So, and then you put your hand under, you subtly put your hand under one leg while you tell them to lift this leg up against you, and you feel the opposing force downward. To lift your leg up, you should push down, right? And if you feel the opposing force here, and then here's the weak. So now here's the weak leg that can't move, or here's the weak leg that can't move. Let's say, and here's the leg that can't move, Okay, so here's the thing, I can't move, and you ask them to lift, and you're not feeling that opposing force, then they're not really truly giving you effort. If they're saying that this leg is strong too. Yeah. So that is actually a pretty sensitive, good positive sign.
Is that the Hoover?
That's Hoover, yeah. And I guess you can do it laterally with the thighs too. I never do it laterally, but I just read about that too. Psychogenic non-epileptic seizures, a lot of the signs would be and this goes in, there's something called dissociation, which is one of the more common symptoms. We should have gone into symptoms of HPI a little bit, I guess. A lot of the times these folks will say when they have one of their conversions, especially the seizure ones, they won't be there. They kind of left their body. They'll be able to tell you that they kind of knew things were going on, and they kind of heard people talking, but they just kind of weren't there. And this dissociation is pretty common. They kind of shut down. It's again, probably it's a horrible PTSD event in their lives that they're just trying to escape out of, that they were recalling or something. Real seizures are usually 30 seconds to 2 minutes long, so if you've got someone going for 20 minutes and they're waking up right away afterwards, that's a big sign. Tongue bite and urinary incontinence, people with conversion disorder and syncope can do too, so those are great signs. The teddy bear sign might still be a good sign, but have you guys heard of labelle indifference? I put that in my note all the time, but I guess it's not a great sign. I didn't realize that. It must be a newer thing, I guess. So labelle indifference was some French dudes obviously realized that people with conversion disorder seem to be indifferent. Yeah, I can't move my leg, whatever.
Yeah.
Where you'd think, well, that should kind of freak you out, right? But they found that in some study that people with real weakness also seem to have this, and they thought it was probably because people, they want to be stoic. They don't want to. They don't want to try to be proud. They're in a vulnerable state when they're in the hospital or anything. That's their theory anyway. So I might stop putting that in my note, even though it's so cool to type some French in my notes. I'm going to have to stop using it, I guess, which is a bummer. The Hoover sign, yes, psychogenic seizures, the semiology or the signs of the seizure can be, this is more the discongruity if they're not making physiologic sense. So a seizure doesn't usually have hip thrusting, usually doesn't have eyes closed, usually doesn't have going no, 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 or yes, yes, yes. It's usually just like a convulsion. It doesn't usually have irregular rhythms. It doesn't usually stop and start and wax and wane. All those things are more typical for conversion disorder. It's not usually associated with just crying before or afterwards. Usually people with conversion disorder, again, because there's probably some horrible trauma that they're reliving or something, will often cry afterwards. It's depressing. That's why I have a lot of sympathy for these folks, because a lot of times most of the other docs are just, and even me, I can be guilty of it, especially if it's so busy and you've got real stuff to deal with, and you've got these crazy people, and then you realize these are people who've been just really abused or something just horrible in their lives oftentimes, and so we have to remember that. I have to remember that. I will just blame myself.
So do you tell them, Dr. Jordan, that they have?
Yeah, I do, and I didn't. When I was new med student, I was kind of following my peers and professors, and hopefully this is an evolution, and it's not that they're still doing it, but that we've all learned that, and this is evidence-based now. Yes, tell them right up, straight up, this is what it is. A lot of people aren't going to accept it, but you might get lucky, so it's still considered a pretty poor prognosis. Overall, the majority probably are going to have recurrent events. It might be too trapped, or maybe we're just not good enough at figuring out how to treat the whole package, the insomnia, the depression, the pain, to get it all taken care of, and get them out of the psychosocial ruts that they're in. It can be overwhelming. We can only do so much, especially just in the hospital, or as even a society, even a rich one like ours. But yeah, you got a lot of folks who might be uncomfortable talking about psychiatric issues, or who still have psychiatric biases themselves. Psychiatric disorders have been taboo for millennia. It's the demons that are in you, and kick them out of the. If you're not the lucky one that gets to be the Apollo soothsayer, you're usually the crazy that you get stoned to death or burned to death or kicked out of the village, right? So it's been pretty taboo to even talk about psychiatry without taboo just over the last 100 years or whatever. So that's still lingering. People don't want to be crazy or have people do this behind their back and all that stuff. So we're uncomfortable. I don't want to tell them they're crazy. I mean,
How do you tell them? Like if I have it, you say to
I
me,
wish you guys could see me. Like,
Yeah.
like half the code, it seems like half the code strokes are conversion disorders. So I just tell them right there. No, you're not half. I just had one the other day, so she's probably just fresh in my head. It's like, I know you. This is like the 10th time. Like, wait a minute. Don't do the CAT scan. We have irradiated this lady's brain. It's going to be glowing. And, medical, legal, defensive medicine, the ear docs were thankful that someone was going to do that because they were like, and they're like, could you document that you said I didn't have a CAT scan? Yes, I will. I don't care. Let them sue me. They are not getting another bloody CAT scan for that is not aphasia. That is not how aphasia works. But yeah, this lady was CAT scanned 9 times, scanning for 4 code strokes in 2 years for talk. Like, let's call the ambulance, put them in the CAT scan machine, admit them for 2 to 3 days, probably cost this hospital and this community $250,000 to $500,000, God only knows. And, maybe given her brain cancer in 10 years. I mean, this is the bad thing about conversion disorder is they get iatrogenic complications. People are afraid either because of defensive medicine or they really just aren't sure and they want to be safe, especially if they're new to you. I mean, I usually do that. I do the full workup. Like going back to your question of the full H&P, I also do the full workup. Even from the very beginning when I first visit with a patient, I know it's probably bogus. Just at least if I've never met them, just the first time through, do the full workup. Part of that is even the treatment, because again, reassurance is part of the treatment. You can say, look, your spine is totally fine, your brain is totally fine. There's nothing organically wrong that I can find. Your EEG is fine.
and that's how you tell them it might be.
Yeah. I don't jump right into it, I guess, because that again is the trust thing. It's like not jumping right into the possible abuse in the past.
Yeah.
But when I'm at here's the conclusion of my stay or my visit, here is my assessment and plan and what we're going to do. I say, well, you present, say it's a psychogenic non-epileptic seizure. One thing I don't do that I just read that they recommend doing. I still don't know if I agree with this. I'm not going to recommend this myself until I read evidence for this. They actually recommend not only telling them that for sure, this is something we would probably call a conversion disorder. It manifests outwardly and looks a lot like, in this case, maybe a seizure. Here's why I don't think it's a seizure. The EEGs have been normal. The MRI is normal. You don't have any epilepsy risk factors. Like concussions or brain tumors or meningitis as a kid or something. And there are a lot. I usually say there are a lot of findings on your physical exam, or if it was the Hoover thing, or on your in watching the seizure, that were non-physiologic or discongruous. The things that just don't usually happen with this disease or disorder. So I'm got a high level of certainty I'm going to diagnose something called conversion disorder, which is more of a mind issue. A lot of people will start to use different words. I usually say it's a psychiatric disorder. I usually say it's part of the anxiety disorders, because it is. It's kind of one of the subgroups of the anxiety disorders. I usually tell them, I'm not going to go into it too much because I'm not a psychiatrist. I'll tell you what I know, but I don't want to give you misinformation. I want you to see a psychiatrist about it. But I consider it something sort of like a panic attack or the dissociation, something where something is so stressful in your life that you just have to shut down and you leave, and then your body does something weird that you're not even around for. And this is all verified by studies as well. To tell them point blank what it is and reassure them that everything looks great. The good news is you don't have epilepsy, you don't have a brain tumor, or whatever. You don't have MS is another common functional weakness with MS, which can overlay. Real epilepsy patients can have pseudoseizures. Real MS patients can have functional weakness. Where was I? Reassurance. Tell them exactly what the disorder is, and then the third thing was, oh darn, I forgot.
You tell them what you expect the outcome. Like, I expect your arm will get strength will return. You kind of tell them what you expect.
Although, here's the honest prognosis. I kind of like, I'm a real rationalist. I'm kind of a secular humanist rationalist person who is very non-supernatural. So I I'm a science nerd, Spock kind of objectivist, or I'm not a Henriette, but that kind of thing. So I would, and probably because I'm biased, I guess I feel people out. There's some of your little ladies and little men who I don't know, doc, don't tell me that stuff, you just do what you think is right. You know, some people don't want to know stuff, then I might not go into it. But otherwise, if I don't feel that, I lay everything out really bluntly and honestly with folks, because that's how I would want it, you know. So
you tell them the plan of care then?
Well, going back to the prognosis or the treatment and the plan of care, is that, so the true prognosis of this is that there is a minority of folks who can do really well. They tend to be younger, it tends to be their first attack. Maybe some big stressor, like, you know, my girlfriend just left me and all of a sudden I can't do this or whatever. You tell them, you know, you go through everything, you reassure them, everything's cool. And you say, I think this is sort of, I call it like an anxiety thing, a panic attack. The real word is conversion disorder if you want to Google it. But I think, you know, your mind's kind of shutting down and it manifests this. And the good news is everything's right. I'd like you to see a psychiatrist, make sure I'm not missing anything. But yeah, I'm hopeful that, you know, maybe we nip this in the bud and, you know, with that knowledge, you know, when you look out for your stressors, maybe you'll get through it. And I get lucky, you know. I think more than what the review article said is a minority. I would say 25 to 50% of the time I get people going, you know, I think you're right. I think, you know, I've been through a heck of a lot. But you still get 50% of the time, like, so you're saying nothing's wrong with me? And then I say, no, I'm not saying that. Something's obviously very wrong with you. You can't walk right now. That's not good. But I'm just saying it's not a spine, nerve, muscle thing. It's somewhere in here. And it's obviously... I let them know that in some ways it's good news because you don't have MS and you're disabled from that. In some ways it's bad news because you have something that might be, you might have something even harder to treat. You know, if it was seizures, I could throw Keppra at you and we might stop and bing, bang, boom, you're going home. And psychogenic non-epileptic seizures, you probably have years of cognitive behavioral therapy and psychosocial work and if to really get your life functioning back to normal. Okay. So in some ways it's a lot harder. Yes, so I do warn them that hopefully you're going to be one of these lucky ones, but if not, you know, and the treatment plan is still, when they get discharged, they should, even if, you know, again, I just didn't agree with this review article. So the one thing the review article said that I didn't agree with, the first one was, let them know on the physical exam findings on why. So let them know the Hoover sign. See, you were supposed to push down and you didn't. Or let them know on the seizure. See, your seizure should have been a minute. You should have done this more and you did this more. You know, they totally come back. They learn it. And it's subconscious. I give them the benefit of the doubt. I don't think they're, well, one, they might be fictitious or malingering. I don't know that for sure either. But two, even subconscious. And I had professors say that too when I was a, you know, innocent little neurology resident. I told them, yeah, and then I told them that we knew it wasn't a seizure because they closed their eyes. Why didn't you tell them that? I don't know. Why was I supposed to tell them that?
I think this is why with our treatment, Dr. Jordan, we tell them what their expectations are. Like the next visit, we anticipate, yes, you're going to be able to raise your arm, so they have that set in that.
Yeah, I do. No, I do tell them that. I guess that's, yeah, well, your question was, you know, the good news is it's not, it's probably in the mind's functional, it's some sort of anxiety disorder thing. The bad news is it might be hard to treat in the long term, but in the short term, you will move that arm again. It might take a day, it might take a week, and it might get weak again in the future. But yeah, I do encourage them that this is going to get better. It's just, it might be tough. So I don't tell, the one thing I didn't agree with, I don't tell them that what my tricks are, because they learn. People just hear it, and oh, you're right, but they're not cured, and they come in with another seizure. I think I told you guys in the seizure thing, the real seizures and the pseudo seizures, and how we haven't done the study. We seem to correlate it with IQ, maybe, because someone with pretty bad MRDD, probably an IQ of 60 to 80, came in and their seizure was like this, I'm having a seizure, literally, and we were like, whoa. And mom was like, what is it? So, okay, this is going to be easy. Then we had, this was in Cleveland, then we had like, you know, a CEO or vice president or something, a key bank or whatever, immaculate, professional, yuppie power woman, really sharp, asked good questions, and then, okay, well, look, you know, and we were not sure, let's put her in the EMU, and hooked her up, and then she had her seizure, and while we were all talking about it, and she started doing the, and we were like,
What's going on?
Look, is she on the EEG? What's going on in the EEG? Totally normal. Like, wow, holy mackerel. So that's when we came up with our theory. Maybe I'll do a trial. See if IQ correlates with semiology, physiologic semiology.
Oh, I was just saying, I saw a patient, I think it was a month or two ago, and she did have a developmental delay, and I remember reading your notes.
So these are really seizures. Did she have real seizures? They
No, she
definitely
had
have real
seizures.
seizures
It was
too.
such a pseudo seizures, and you had told her, like, you need to open your eyes because we need to know if this is a real seizure or not, and she woke up out of her seizure.
Well, I told her, I kind of gave it away there. I shouldn't have done that. But I remember her because, yeah, that was what was reassuring. I mean, whenever someone has a seizure, not sure if it's a seizure, you see if they can stop it. So if it's twitching the leg, you see if they can stop, or you try to stop it. And if you really can't, that's concerning. So for her, yeah.
Yeah, and then the nurses just started giving her saline flushes to because she would start having one, and they're like, we're gonna give you something to make it go away, and then they give her a saline flush.
There's a lot of ethical articles on not doing that. If they use that terminology, that might be okay. We're going to give you something to make it go away. That might be okay. Like someone who's more sophisticated who knows Ativan is used to treat seizures would say, I need my Ativan, and if you're giving them saline, that's not considered copacetic. But that might be okay. I'm sorry.
I just have a question for, here at Providence, care management of these people, because what happens is they have mobility and ADL's issues because of this dysfunction, and so it gets determined that it's non-organic in nature, and then what do we do from here? And often, you guys appropriately will sign off from a neurological perspective when you made the diagnosis, and so then the hospitalist and the therapy team are sitting there going, what do we do with this person because they're not walking?
So,
the rehab thing.
There is PT rehab evidence that that is good treatment for these folks. Now, it seems like why they're not really weak, but so maybe it plays into a daily reassurance treatment. It is nice.
That's what it is.
It is nice because and you're giving the same treatment you would give to anyone who's got weakness. Remember to look back on that. Remember to use that other leg when you're moving that leg. You're retraining them to. And they're being taken seriously. That was the other point to going through the whole physical exam, because a lot of times these folks are not taken seriously. They feel dissed, again, because of the psychiatric taboo. So I'm going to treat you like any other patient. I'm going to do the full exam, do the full assessment. And they like that. You're not like treat me like I'm some crazy person, because they've obviously, especially the folks who unfortunately probably have it pretty bad because they've been to multiple hospitals with the same thing. At that point, they really are getting frustrated because people are just, get her out of the ER, she's crazy, get her out, or he. Sorry, so I think they like that. So the first line of treatment is really education. Right there, you can be lucky and nip it in the bud right there sometimes, especially if it was, again, a younger person first attack. But then it's more counseling and definitely a psychiatry consultation if you can. We were talking about this the other day. Psychiatry, I don't know if it's still true, can't see people Thursday, Friday, Saturday. And so if it's a patient who's otherwise doing okay on Thursday, MHD is going to, and the length of stay and everything else is going to get them out. And if they still can't walk, then they're going to go to a rehab place with cognitive therapy, psychological counseling. But it would be better to get all these folks with a psychiatry consultation, especially because a lot of them will have comorbid psychiatric disease that maybe isn't treated, depression or anxiety or bipolar disorder or something. But the second line of treatment is then the more, tell me about your mother, cognitive behavioral therapy, PhD psychologists, and physical therapy. Those are the two second line treatments. And again, it's probably the reassurance thing, I guess. So you guys are like our OT, PT, and ST are the treatment for psychogenic weakness or speech therapy or speech disorders.
Is there any specific difference between using the term conversion disorder versus functional neurological symptom disorder? No,
it's the same thing. You can use it. There's actually 5 or 6 you could use.
Dr. Cantini over at Inpatient Rehab prefers is that we.
I was wondering about the ICD. Like, what do they leave here with? Would it be weakness or conversion if it's?
Conversion disorder to me is the catch-all for all of them, so it's the easiest one to remember. But yeah, you could call it dissociative disorder if it's just someone who's just leaving themselves. You could call it functional neurologic disorder if it's a weakness. You can call it psychogenic non-epileptic seizures. All of these have 5CD9 T10 codes in them. Conversion disorder kind of catches all of them. And then third line of treatment, which I've never gotten into because this is more of a outpatient thing, is if the PT isn't working and you've tried treating everything else and SSRIs for any comorbid depression and education, you can go to things like hypnosis, things that are sort of complementary alternative medicine. At this point, as long as they're not doing any harm, some of the complementary alternative medicine theoretically might do harm. So I don't want cervical manipulation from a chiropractor or something, because that could cause a stroke. No comment. If I don't want to get into a chiropractor battle here, but hypnosis is benign enough. Suggestibility can sometimes work. Just anything you can think of to try to help these folks through it. I mean, a lot of it is if you could write these patients $1 million check, that could treat half of them probably. So get involved in politics.
And when you say PT, you mean PT/OT?
PT/OTST. Yeah, I know. I tried the PT/OTST. I know. I tried to throw that at the end. I'm like, oh crap! I've been saying PT the entire time. I'm sorry. Therapist. And
That's what we mean, Darlene.
So, and then we were talking briefly yesterday. So, where do these folks go? There's not great psychiatry, but I didn't realize that until I re-reviewed it yesterday and today. Since physical therapy is actually such a evidence-based good therapy to get these folks back. OT and ST.
You're okay. I decided not to throw M&Ms at you.
I just should say therapy.
So close.
Since those are evidence-based good treatments, then we should it definitely seems now okay to me that they're going to these places. We were saying, in Cleveland, we actually sent a lot of these folks to our psych ward, where they would do, which is more considered the third line hypnosis kind of thing, the group therapy sessions. And it might have been more appropriate that they actually went to a rehab place where they got both PT and cognitive behavioral therapy of some sort. So that might be actually the better strategy for these folks anyway, so that's good. It makes me happy that maybe we're not doing the wrong thing.
How many of these conversions are actually going to SNFs? Because my experience with SNFs is they do not have the psych services.
Yeah, no, they're not supposed to. Again, we're not admitting or discharging service, and so we don't get into the nitty-gritty with the discharge planning as much as we hopefully will have time to at some point. But we leave in our notes, at least I do in my notes, that this person needs a rehab place with psychological counseling. They basically need the psychological counseling. Sometimes they will refuse it because you're going to have the folks who don't believe this has anything to do with their head, and I'm not under any stress. I don't know what you're talking about. And if that's the case, physical therapy is still the best option. It's still the best treatment thing for them at that point.
Sometimes.
OT and ST. Sorry. Therapy.
Just say therapy.
Therapy. I know I'm trying. I'm just not. It's a creature of habit.
Sometimes these people that have the conversion disorder type of things are homeless.
I know.
And don't have the option to go to SNF, and
I
then
know.
they end up in psychiatry because that's the only.
You mean a psychiatric ward,
Yes.
inpatient ward?
Yeah, and
Yeah.
that's the only place they can go.
Yep. Yeah. No. Homeless. This is going to be just a bigger issue.
We used to
Like the
have.
Seattle issue that just happened the other day. This is going to be a gargantuan issue in this
Well, I know we
country.
used to have a physiatrist who refused to take conversion disorders. He said, his comments were, just send them to a SNF, they'll get over it. Or they'll hate it and they'll just.
See that?
I'm just wondering.
No, that's too bad. I have no comment on that psychiatrist case, but the treatment. We can end on this if it's getting late for folks. The treatment is and should always still be that. I think the reassurance is really the treatment to if you're going to get lucky and break them out of it. Besides trying to deal with all the other comorbid real illnesses and psychosocial issues that we can't do everything for everybody, and this is a bootstrap libertarian kind of country. But the best we can treat those issues might help them, and then the actual disorder, the treatment plan should be quick. If they've been lost, fall, whatever, frequent follow-ups. And for me, if it's a neurologic disorder, it's with their primary care doc, an outside neurologist, and a psychiatrist, like in a month. And then after that, in 1 to 2 months. And then after that, in 2 to 4 months. And then after that, it's going to cost a lot. They're not going to have insurance, and this is never going to work because they're going to get lost and be homeless again within a month. So this is a pipe dream, but this is what should happen to these folks because the study showed if they have the frequent follow-up, and even if I'm clear this is not epilepsy, at least one, the neurologist might be able to drop out if it's not a real neurologic disorder after 1 or 2 follow-ups. But if that was their key neurologic disorder, they're going to keep coming back with the pseudo-seizure, and reassurance is the treatment, so they should be seeing the professional of seizures, who's the neurologist, to reassure them at least a couple times. Yes, it's been another month. I heard you had another one of those events, and once again, I really don't think that's a real, an organic seizure because, da, 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 da. And so if you do it frequently enough and do studies that are reasonable, not too expensive, not too invasive or radiating, as treatment for it really more than diagnosing, unless you're concerned that you might be having that 10% that might have something real and curveball that you miss. That would be the best treatment plan. So the psychiatrist who's like, they're just crazy, they need to go to rehab and not bother me, that's, I don't agree with that.
Well, we're kind of stuck, because we made the recommendation at IRF, but then he wouldn't accept them because
Maybe it's better.
they were a psych case.
Yeah, I just want to clarify that the medical director now believes in this and he does expect it.
Yeah, this was something.
This is true with neurology too. I recommend in my notes that they should see a neurologist for follow-up even though I've diagnosed conversion disorder, psychogenic non-epileptic seizures. There'll be neurologists that say, then I don't need to see him. Why are you making me follow up with this patient? They just disagree with what I think is the right treatment plan for these folks. And that's fair. They're their own person, I guess. It's hard to find docs that will take on psychiatric patients in general and conversion disorder. When you're talking about a non-psychiatrist taking on a psychiatric patient, it's always a somatoform conversion type of disorder. And all subspecialties of medicine have. GI has 10% of the cases are the psychiatric GI problems, and cardiac, the atypical chest pain. All the subspecialty physicians have a subset of primarily psychiatric component of their specialty, and it's really hard to find those who are okay seeing them a couple times for the reassurance thing. It's too bad because it probably might help. I don't know. We've never done it in the world. Maybe that's what would get the numbers down if we would do it more.
We had a patient on 5 that was absent from everything. She got lost for 3 days in the woods, and then they found her, and then she had the kidney thing in her abdo and such. And then
Lost.
later,
Was she dementia?
I think she was on drugs. I don't remember her.
I remember her.
She was on drugs, and then they said she tried to commit suicide, so eventually she admitted maybe that was what she had done. She's naked and lost.
She was gone for a couple days.
Yeah. And when she came out of it, though, she was weak and everything like that, but later they said conversion. So I'm wondering at what line do you go from?
How was she admitted? What were symptoms? What did you,
I can't remember.
Was the
Kidney, it was kidney issues.
So,
right?
was conversion the only diagnosis? Was that one of
No,
like
that
5
came
or
later.
6?
That came later after the weakness didn't get stronger. So the rhabdo didn't resolve.
Maybe this is a person who was out homeless and needed the hot in a cot and was desperate. And they came in with real renal failure and real generalized weakness from uremia. They got treated, they were getting better, but they realized I'm about to be kicked back out there. I have PTSD, I cannot sleep in the cold again, and they started being weak.
So then you become
that's reasonable. I can see a human being doing that.
One of the other definitions, like malingering type of definition?
If it was conscious, again, I don't go there.
Yeah,
Because you can't prove, it's hard to prove intent. That's like for either a psychiatrist or a judge. It's hard. You can have a hunch and you can be pretty sure even. Sometimes in the epilepsy world, because we've got people on video, we can do it. They don't, if they forget the video's on, oh, okay, I'm going to get Batman. Again, no one does the sinister thing. But you could be like on video, got you, sucker!
Been lingering a lot with the L9.
Wait for the what?
L9.
Oh, yeah, anyone who wants disability, that's, a car crash, this is outpatient neurology. I used to get a lot of that with outpatient neurology, a lot of folks who had a car crash 5 years ago, and now they really, I really need the disability papers. They have to be really careful. And
It's just something I was curious about.
again, if we all get to write people $1 million checks, or have the Inequality or Society code a little like this, my guess is a lot of this wouldn't happen. That's my personal political opinion. I'm not supposed to talk about politics. That's not a problem. It's sanctioned belief.
Okay, have a good day.